to the didactic, and I'll turn it over to Dr. Finkel, who will be talking about hepatitis B prevention.
Great, thank you. I'm going to share my screen. Can you guys see the slides okay?
Yep, looks great.
All right, great. So I was asked to talk about vaccination today, and I'll just say from the beginning, my bias in the presentation is going to be toward adult vaccination, just because I'm an adult provider. Obviously, we've been vaccinating kids for hepatitis B for a long time. We've got a number of very effective vaccines for children. But I think the reason why we wanted to focus on this a little bit today was based on some new guidance that came out in the last year, which definitely changes how we think about hepatitis B vaccination. I have some disclosures at the bottom. None of them are particularly relevant to today's talk, but I always show that. So hepatitis B vaccination is really important because this is a vaccine preventable illness. And for patients who have not been vaccinated or are still susceptible to hepatitis B, vaccinating them for hepatitis B obviously could prevent them from getting the infection. This was just, I really like the Hep B Foundation's call to action from this past March, so I might have borrowed a couple of graphics from there for this talk. But the key point here is this right side for this talk, where the reason why some recommendations changed had to do with the fact that 70% of adults haven't completed a hepatitis B vaccine series in the US. And this was an opportunity to help these patients prevent infection. And where we're seeing hepatitis B infections is in this sort of adult population, since most of the under 19 people have been vaccinated in the US. So as of 2022, the ACIP put out new recommendations for hepatitis B vaccination. And some of them are the same. So it's still recommended that all infants and all people under 19 years old should be vaccinated. But what's new are now that all adults up until age 59 are recommended to be vaccinated for hepatitis B. Adults who are over 60 with risk factors for hepatitis B are recommended to be vaccinated. And adults over 60 without risk factors could also be vaccinated if they desire. So why this change? It had to do a lot in part due to epidemiology. So most of the acute hepatitis B cases in the US were occurring in patients under age 60. And as we saw earlier, about 70% of the adults in the US are not vaccinated for hepatitis B. Along with this has been the whole hepatitis elimination plan from the WHO. And in order for us to fully eliminate hepatitis B, we need to vaccinate those who may be susceptible so that infections can't continue to spread in our community. Just to review quickly what the risk factors for hepatitis B are, as we mentioned, particularly in that older adult age group, if you're 60 plus and have a risk factor for hepatitis, then vaccination is recommended. So the risk factors, most of these should be familiar to people on this call, but people can be at risk via sexual exposure. They can be at risk via blood exposure or body fluid exposure. And this could be either through drug use or through workplace risks, such as healthcare workers or public safety workers. It can be from dialysis centers or even patients who take diabetes and need needles or lancets for that. There were a couple new things added to the list of risk factors for hepatitis B in the most recent call out, and these included people who are incarcerated. Historically, we've looked at patients who travel from other countries or were born in another country. But in particular, if you're going to travel to a country with higher intermediate level of hepatitis B infection, so more than a 2% prevalence or higher, and you're going to be there for a while, those are other people that may benefit from vaccination too. And what didn't change really were people who have other infections that put them at risk of Hep B, like HIV or Hep C, or anybody in my practice who has chronic liver disease should be vaccinated as well. So let's get into the nitty-gritty a little bit about the vaccines that are available. So currently we have 5 available vaccines for adults. 4 of them are 3-dose vaccines, which are dosed the first day, a month later, and 6 months later. And these include Recombivax, Engerix-B, Twinrix, and Prehevbrio. The Twinrix is a combination hepatitis A and B vaccine. And there's one 2-dose vaccine available, Heplisat-B, which is dosed a month apart. All of these vaccines are equally endorsed in the guidance document. There is some data that the 2-dose vaccine may be a better choice for hypo responders to the vaccines. such as those that may have diabetes or older or have obesity. But all of these are really good choices. And I think which one you get sometimes depends on what's available where you are. This was a table I pulled out of the MMWR ACIP recommendation, just looking at how these are dosed. So for people over age 18 years old, or for actually this is more adolescent and older, these are how the medications are dosed and what dose to use. There is a difference in the Endrix B dose, for instance, in adolescents versus adults in terms of the dosage use and volume of the vaccine. Some of them are the same. So like the Heplisav B, Twinrix, and Prehebrio are one dose. I will call out that the bottom three vaccines there are currently only approved in adults and not in adolescents or children. Just some key points to think about with these vaccines. So there are some subtle differences. So some of them are single antigen vaccines. So the Recombivavax and the Endrix B both contain a little bit of Hep B surface antigen to provoke the immune response. Prehebrio is a 3 antigen vaccine that is thought to be a little bit more immunogenic. There are 2 vaccines that use an adjuvant to achieve this. So Heplisav B uses an adjuvant that stimulates a specific receptor, the toll-like receptor 9 in the immune system, to provoke a more robust response to surface antigen. And the Prehebrio uses an aluminum hydroxide adjuvant to bind the antigens and effectively deliver them. I mentioned there's the dosing differences between them. So most of them are 3 doses, and the Heplisav B is a 2-dose vaccine. It's also notable to point out that if you get a vaccine and you're also undergoing triple panel screening, for instance, for hepatitis B, you want to try not to do them for 3 or 4 weeks after a vaccine. There's data at least 18 days or more where you can still see a false positive surface antigen in patients who've recently been vaccinated. So for centers that are looking to combine the screening recommendation with the vaccine recommendation, you either want to do the screening first and then the vaccine, or you want to do the vaccine and wait a month and then do the screening. But it's hard to do them where you give a vaccine and then draw blood because you're probably going to get a false positive antigen. In pregnancy, it's the newer vaccines like the Prehebrio and Heplisav B haven't had great published data in the pregnancy population yet. There's really good data that it's safe to vaccinate with the older vaccines in the pregnant population, and all pregnant patients are going to get screened for hepatitis B as well. The good news is the vaccines are very safe. Side effects are very uncommon and usually occur in less than 10% of patients. Most common just being like injection site pain from any needle you get in your body. Some people get some redness or swelling at the vaccine site, and occasionally you can get some fatigue or muscle aches for a day or 2 after the vaccine. But I generally reassure patients that these are proven vaccines. They've been out for a long time, and most patients do very well with them. How effective are they? So to measure effectiveness, we look at something called the seroprotective rate. I just pulled the data from some of the registration trials and the comparison trials for these vaccines, but in general, all the vaccines that are Hep B specific are very effective with more than 75% seroprotective rate, meaning that patients will develop measurable surface antibody titers over 10 milli-international units per ml after finishing the vaccine series. And there's some sort of, you can't exactly compare head to head the specific numbers because the populations of patients they're studying are a little different. But in general, you're getting really good responses for most regular patient populations. There are some populations we know respond less well to vaccines, and in some of these populations, higher doses or more doses may be necessary. So for immune-compromised patients, dialysis patients, diabetics, obesity, and patients with chronic liver disease are populations of patients who are generally known to respond a little less well to vaccination. Where can you get these vaccines? In my practice, we carry them in our office. A lot of providers do carry vaccines in their office. You can get them from pharmacies, and there are also sponsored vaccination events. In my experience, the ones that you get at the doctor's visit tend to be the least expensive to the patient. So they're often bundled into the cost of the visit, and there's not usually additional cost to the patient. So if I see a patient in the office and we offer them hepatitis B vaccine while they're there, usually that's fine. They don't get an extra charge for that. If you get it at a pharmacy, a lot of patients do have cost sharing associated with that. So it could be in the form of a copay. If they have a deductible, sometimes they have to pay for the full cost of the vaccine until their deductible is paid down. And this can definitely be insurance specific and geographically specific. If you need help finding a pharmacy that carries it, in the city of Philadelphia, at least, HepCap put together a tool on their website where you can find vaccines that carry hepatitis B vaccinations. In Philadelphia, also, there is another program that if you're a provider looking to get vaccine in your office and don't have it at the moment, it's called VFAR, stands for Vaccines for Adults at Risk, which I think other cities have this as well, but in Philadelphia, at least is the one I'm familiar with, where you can providers can get basically free vaccine supplied by the government for patients. They just can't charge the patients for the vaccine. This includes both hepatitis A and B vaccines. So if it's something where you're thinking about getting vaccinations in your office and you want to get more information about this, you can reach out to the city at this email address listed here, philavax@phila.gov. And I think the other thing to consider, these are not one-time vaccines. So it's not the flu shot that you get annually. This is a one-time series, but it's going to be at least 2 doses and sometimes 3 doses for patients. So I think it's important to have some kind of recall system in place. And the challenge I often will run into, for instance, is I might see a patient that lives 2 hours away and I have them in my office and I can give them the first dose, but they don't want to come back a month later to get the second dose. And that's the challenge where you have to see, can the pharmacy get it, or should you just have their primary doctor do it all local to them? Those are a couple options there. I'll mention a little bit about vaccine non-responders because this often comes up. And so we would define a vaccine non-responder as somebody who fails to achieve a measurable antibody titer to surface antibody after finishing the vaccine series. And there's a couple ways to think about this. So if you have somebody who, maybe didn't finish their series in the past, I wouldn't necessarily call that person a non-responder. They just may not have finished the series enough to get a response. So in those scenarios, you can often just revaccinate them with a full titer, full series. You could potentially check the titer of surface antibody, and some people do get lucky and maybe don't need the whole series. And if they do have measurable antibodies, they may just be lucky and they're done. But in patients who have a documented full series completion, who still don't have measurable antibody titers and don't have chronic hepatitis B, then you would call them a non-responder. I do want to point out that at the moment, at least, people who don't have a reason to be immune compromised in particular, or in an occupation where they could get hepatitis B, as long as you've documented that you finished the series, usually we're not checking titers in these patients. So you may not really know if somebody's a vaccine non-responder or not. But there are populations of patients such as healthcare workers or dialysis patients or immune compromised patients where understanding whether they responded to the vaccine can have added value to the patient as well as to the healthcare situation that they're in, whether it's for their healthcare system or for their employer. There is specific recommendation about what to do with these patients. So if you are a vaccine non-responder, there's the 2018 MMWR guidance document about how to deal with these patients and who you would consider to check titers in. And so basically in this scenario, if you're one of those people that needs to find out if you've responded to the vaccine, such as a new doctor at a hospital, what you can do is you measure the titer. If it's below the number, you can get 1 dose of a booster dose vaccine, if you will, and then come back a month later and check the titer again. If it goes above 10, you're done. And if it doesn't go above 10, then you get the whole series again. Dialysis patients are a slightly different population because there's a fear of spreading hepatitis through dialysis units. Those patients generally get their titers checked annually. And if they remain below, they may get a booster every year to try to keep their titers up. Chronic kidney disease often leads to an underproduction of measurable antibodies. As far as immunocompromised patients, there's not clear guidance about what to do with these populations. So, I see a lot of liver transplant patients, for instance, I think generally speaking, as long as we know they've taken the whole series, if they're not in a high risk scenario, we're not too worried that they're going to get hepatitis B again. But if there's somebody who may have ongoing risk for hepatitis B infection, such as active drug use or ongoing dialysis, they may get boosted or revaccinated. So just to summarize, take-home points from the vaccine discussion are that since 2022, all adults up to age 60 should be routinely vaccinated for hepatitis B. If you're over 60 with the risk factors, you should be vaccinated. If you're over 60 without risk factors, you might be vaccinated or may be vaccinated. There are multiple vaccine choices available, both 2 and 3 dose options that are all highly efficacious. You don't need to check to see if the vaccines worked if the patient has finished the whole series, unless they fall into a special group like an immune compromised dialysis or healthcare worker. And protecting our population from Hep B is really a key step toward elimination. So really, we're trying to protect the pool of people at risk for hepatitis B and try to keep it out of everybody else. And I'm happy to take any questions that you have. I just added into the slides here some key resources that you might want to refer to. I called into attention the Hep B vaccination statement from 2022 from the CDC, as well as the ACIP report in 2018 that highlights the non-responder populations, and also the Hep B call to action, Hep B Foundation's call to action from this year. And immunize.org is another great site that has a good FAQ page if there's any questions that people have. Thanks very much for your time. Happy to take any questions you have.
Thank you. If anybody has any questions at this time, you can raise your hand or put things in the chat box and we'll get to them. I had a question about non-responders. Do you know about the volume maybe of the non-responders?
Like how many people don't respond?
Right.
I mean, I think it's just the inverse of the seroprotective rate, I guess. So if the vaccines are 90% effective, you expect about 10% of patients may be non-responders.
Got it.
On average.
Got it. And then just because I noticed that we have an international audience today on the call, I did want to just point out that the Heplisav-B is only available, the 2-dose vaccine in the United States at this time. And then PreHevbrio is international, but it is, I don't think, to my knowledge, and if somebody can correct me from that company, that would be great. But I did some research. It's available in the UK, US, Israel, Canada, and the EU. So it has limitations as well. Great. Any other questions? Great. So I did pull an FAQ from some of the common questions that we get at the Hep B Foundation that I think, Britch, I see you have your hand up. Feel free to unmute yourself.
Okay. Okay, thank you. I have one question. There was one surgeon in an institution I was working, and he developed GBS after he took immunoglobulin with vaccine within short period of time, and it was actually severe. My question is to what we are attributing the development of GBS? Is it the immunoglobulin he took or the HPV vaccine, and how common is it in general? Thank you.
I'm not going to claim to be an expert on Guillain-Barré syndrome. I know there's reports of GBS after many different kinds of vaccines, including flu vaccine and pneumococcal vaccine and other things. Any sort of immune stimulating component, I think, could potentially put you at risk for that. So it is difficult to distinguish between the immune globulin that they might have received and the vaccine. Do you know, like, was it the first dose of their vaccine series, or was it after the whole series had been completed?
Actually developed the disease after he took the first dose of vaccine with immunoglobulin.
Yeah, I think that's a hard one to answer temporally, and you've got two potential things at once. I guess in that scenario, if you're also giving them immune globulins, you might be giving them passive surface antibodies too. So in some ways, if that's a regular thing, there could be protection against hepatitis B, even if they can't finish the series. I mean, I think that's probably a case where you might want to involve an immunologist just to see is there a likelihood of that happening again from another vaccine or not. Sorry, I can't give you a good answer on that.
Yeah, that's a really difficult question. I see we have a comment in the chat from Bright. Do we give a false sense of hope to new employees if we only test antibodies during the hiring process? Why don't we test both hepatitis B surface antigen and antibody?
I think you highlighted one of my pet peeves about employment physicals, because I've definitely seen patients who, they get an antibody and they're told they're good, but really they had core antibody and surface antibody, and then they end up having Hep B reactivation for some reason down the road and can't believe it because they thought they were fine. I think there's competing priorities there to answer the question. There's sort of like the OSHA healthcare system priority that they don't want our employees to give patients hepatitis. It's not so much about you being protected. It's more about them not giving, us not hurting our patients. There is a component of us being protected as well. And I think for them, they just want to make sure that you have some antibodies, so you're likely to not get sick if you were exposed to somebody who had hepatitis B in their blood. But I completely agree with you, and potentially as the new triple screen guidelines go out and are more heavily utilized, most new employees will either have already been vaccinated because they're young enough that they would have gotten vaccines as children, or they'll have a full triple panel before they get to employment. I would love to see that switch, but to my knowledge, it's not being done routinely.
Yeah, thanks, Bright. That's a great question. Another question, if an unvaccinated person received a blood donation from a vaccinated individual, does the vaccine transfer or is there no effect?
I think it depends on what blood you get. So if you got red blood cells, probably not. If you're getting plasma, yes, it will transfer for a little bit, but it's not going to last forever. So you might get some temporary passive transmission, but it's not a permanent effect.
Thank you. Really good questions, everyone. Another question about follow-up challenges and making sure folks get their second and third dose. And I'll start with Dr. Finkel, but also open up suggestions to others who may have thoughts on how we can really work on making sure folks complete their series. If you have any tips or tricks that have worked in the past, that would help with this.
Yeah, for us, we have a vaccination visiting counter that they don't have to see the provider. They can just come in and have my medical assistant do the vaccine. So it makes it a lot easier to get the patient in because they can come in any day of the week. We try to schedule all the vaccine appointments when they leave the office after the first one, so that they show up in their electronic record and they get a reminder there's an appointment. It's not perfect, but that's kind of the best that we can do. I think systems that have text messaging capacity are also more effective in today's environment, and we're a little slow on that. But the ability for a text reminder would be nice too.
Great. Want to offer Dr. or Katie Nguyen or Dr. Rutland to potentially chime in as well here, since they see a lot of patients at the primary care level as well.
Hi, everybody. I don't have too much to say, except there's still a lot of vaccine hesitancy in the community due to COVID. So hopefully the farther away we get from that, the more convincing we can be. But in general, patients that don't know anyone with hepatitis and are older adults at risk aren't very quick to want to get another vaccine. So it can be a frustrating conversation.
Yeah, thank you for bringing that up as well.
Looks like Bright is offering gift cards to everybody if they come back. I think that's a great idea. In practice, I think there's issues like if it's not a clinical trial for us to do that, we're not supposed to pay our patients to come in. But I think that in a community-based vaccine effort, that's certainly been done.
Yeah, definitely. I think that's probably something we're going to be doing, particularly like within the harm reduction setting coming up too in Philly, to try to incentivize people coming back.
Right.
Any other thoughts on tips or tricks for follow-up and making sure people complete their vaccination series? Frequently asked questions from immunize.org, which has a lot of great helpful FAQs as well that are very clinically focused. So I think that would also be a great resource for providers to check out as well. So the first is I have a patient who is positive for anti-HBC, hepatitis B core antibody, but negative for all of the other serologic markers for hepatitis B. Should he receive the hepatitis B vaccine? And if the positive core is believed to be true positive, then the individual would not require vaccination since they already had hepatitis B infection. They should also be checked to see if it's isolated positive, which could indicate a chronic infection. So they should be tested for DNA as well to assess that isolated core. Can you get hepatitis B testing after the vaccine? Dr. Finkel covered this in his presentation. It's best to wait at least 3 weeks before getting a hepatitis B test. If you're testing and vaccinating on the same day, it's best to do the test first prior to vaccination. When we do testing in Philadelphia at community screening events, we'll do the screening first, and then we'll escort people directly to vaccination after that to make sure that there's no crossover between the two stations. And Dr. Finkel also covered this, but titer levels that are appropriate to indicate full protection and how long does that last. At the foundation, we say a lifetime, and then that marker is 10 international units per milliliter. Revaccination is not necessary once you reach that 10 international units per milliliter. What if the vaccine is interrupted? Do I need to restart the series? If the schedule is interrupted, you do not need to restart the series. You can continue where you left off. There are specific guidelines on immunize.org on the Ask the Expert page, which really state which, depending on which vaccine you received, what those recommendations should look like. Can you use 2 different types of vaccine? For example, the 2-dose or the 3-dose, and what does that schedule look like? This is a question that we're starting to see more and more. Data are limited on the 2 newer vaccinations that are available in the US, the Heplisav-B and the Prehebrio, with the interchangeability of those products. But when feasible, ideally the same manufacturer's vaccine should be used to complete the series. However, vaccination should not be deferred when the manufacturer of the previously administered vaccine is unknown or when the vaccine from the same manufacturer is unavailable. So with the 2-dose or 4-week Hep B series for adults only applies to when both doses in the series consist of Heplisav-B. Series consisting of a combination of 1 dose of Heplisav-B and a vaccine from a different manufacturer consists of 3 total vaccine doses and should adhere to the 3-dose schedule at minimum 4 intervals of weeks between dose 1, 2, and 8 weeks between dose 2, 3, and 16. And doses administered at less than the minimum interval should be repeated. So that's an important consideration. And these details are available on immunize.org, and we will share these all with the notes because I think this is going to be a more common question that we're going to continue to see. And then I think this is the final one. I'm a nurse who received the Hep B series more than 10 years ago and had a positive follow-up titer of at least 10 international units per milliliter. At present, my titer is negative. What should I do now? Nothing that level at one point in your lifetime indicates protection. And you do have immune memory, which would still be protected against hepatitis B. And that is the last FAQ. We'll share these FAQs with you, and we'll also share the link to the immunize.org webpage, which also has helpful FAQs. And I'll turn it over to Dr. Gish as well. I think he has his hand raised again.
Hi, thanks. That was a really, really good session. Jonathan, thanks for your case. I have a question though. Is there consistent messaging, Catherine, about not checking titers after someone receives either 2-dose Heplisav or 3-dose with Prehebrio or the other vaccines? Or is there still messaging about checking titers? Remind me.
That's a good question. I might ask Michaela. I'm not sure what the messaging for titer checking is at this current state, especially with the new guidelines. I don't know if she's still on.
I'm here. Yeah, that's a really good question. I think it's a question that we're getting more and more, and that's something that I don't think CDC has officially put out. I think at best right now, what community groups are trying to get across is, exactly what's needed. But any official messaging, if that's what you're asking, I have not seen any. But I do know that they're working on following up with some clinical questions at the moment. So like all these questions that are being asked today, CDC is listening, they're hearing them, and are trying to figure out how to best address them at the moment. So.
My interpretation is the CDC website says don't check titers, but I can't give you a page number or a reference. So, Kayla, maybe you and I can work on that and then share that out if I'm correct. If I'm not correct, let's correct my advice. But right now, vaccine, say goodbye, no titers, no boosting, and go back and work on the next patient instead of what we consider a waste of time, which is this titer boosting issue. So let's work on that and get the word out. Thank you.
And I think Kendra maybe had her hand raised.
The guidance is in the 2018 MMWR, Dr. Gish.
So what I said, Kendra, is correct from that?
I can send you it. I can't openly discuss it on here, but I can send you the verbiage on there and the page number.
Fantastic. I'll take a look and share that out. Thank you.
Okay.
I'll second that, having re-reviewed them all in preparation for the talk today, that it's the 2018 guidance that specifically calls out not to check titers unless you're in that group of patients that might need to have titers checked for vaccine response, which is basically the healthcare workers, dialysis patients, and immunocompromised people.
Thank you, Jonathan. The blessing.
Perfect. Great. Great discussion. Any other questions from the group about either the case or any of the vaccine FAQs? And I just put the CDC MMWR that we were just referencing in the chat as well, which I think we can confirm from Dr. Finkel as well about those titer recommendations. And then, oh yes, just a comment from Ann Lucy, babies born to Hep B positive moms need post-vaccine serology, and that is correct. Any comments from our panel of experts on that?
Yeah, that's in that box number 7 from the same guidance document as well. I just didn't call attention to it as much because I pre-biased myself that I was focusing on the adults, but yes.
Great. Thank you. Thank you for that comment, Ann. Any other questions, comments, or points of discussion for today's session? All right, hearing none, we will go ahead and conclude. Please keep an eye out for the survey in the chat box for CME credit if you're interested in that. Anusha just posted that. Additionally, our next session is the 4th Thursday in August. We hope to see you all there, and we're still looking for case presentations for that session and welcome anyone who has an interesting case or just a topic of discussion to bring those forward. You can reach out to me if you're interested. Thanks everyone so much for attending today. We really appreciate it and hope everybody has a great World Hepatitis Day tomorrow. Definitely post on social media and be active with your colleagues to get the word out about World Hepatitis Day. And we look forward to seeing you all next month. Thank you all so much.
Thanks, everybody.